course on decoding the challenges of postgraduate training. And thanks to all who are here, in spite of not having lunch or in spite of having had lunch. So postgraduate training and education have been seeing a paradigm shift in the recent era. One is because the National Medical Commission has come up with a curriculum. So there are some changes which have been brought about because of that curriculum. On the part of the PGs, there is a significant reliance on e-learning now, and less learning is indulged into from direct patient care. And then there are n number of postgraduate trainings who come out each year from various medical colleges. Like talking of my own college, we have 30 postgraduate MS students coming out every year. So at one point of time, we have more than 100 PG trainees in the college at various levels of their learning. So there is that competitive environment which is there, that professional exploitation because of the vacancies and work issues and crisis of work and work criteria, and sometimes which leads to stress and frustration and burnout, and even unfortunately sometimes deviation from ethical practices. So through this IC, we basically aim to identify all these challenges which exist in PG training and try to identify certain best practices and remedial measures which we can adopt at various levels, maybe not at a national level, but at least individually or at the departmental level or at the institutional level, whatever changes we can bring about. This IC is all about that. Next slide, please. Next slide. So in this IC, we have, Balancing Clinical Exposure and E-Learning by Dr. Vaishali Une, who is a medical teacher and professor from Aurangabad, more than 25 years of experience. Then we have Coping with Stress and Burnout in Ophthalmology to be discussed by Dr. Naina Poddar, who is also a senior experienced teacher from Mumbai. Myself, Dr. Purvi Bhagat, I am the professor and head of glaucoma clinic in the MNJ Regional Institute of Ophthalmology at Ahmedabad. So I'll be discussing the various challenges that exist with respect to training of surgical skills. Dr. Madhav Ambekar from Jalna, he'll be talking on ethical dilemmas in patient care during PG training. He has also vast experience about training at the local, national and international levels. Dr. Jatinder Bali from Delhi, he will be evaluating the current ophthalmology curriculum and assessment. And finally, we'll be having Dr. Usha Johari Madam, a very senior consultant from Mumbai, who will be talking about the role of faculty in mentorship and guidance. So I invite Dr. Vaishali Une to begin her talk on balancing clinical exposure and e-learning.
Hello. Yeah. So good afternoon all. I'm glad to see few PG students and few faculties. So at the outset, I'd like to thank Purvi ma'am and Dr. Madhav Ambekar for having me in this wonderful IC about PG students. PG students have always been very close to our heart, and we want them to learn the best before they go out as consultants in the society. So nowadays, because of the pandemic, COVID has changed a lot of training and teaching things in not only in ophthalmology but everywhere. So the e-learning part has come in a big way, and students now, like in our generation, we were totally dependent on the clinical work and on our teachers, but nowadays students have an access to e-learning as well. So let's find out how to maintain a good balance. So residency consists of heavy hard work, emergency duties, and learning from teachers and the immediate seniors. But this has been changed, of course, and now we have to blend both and titrate each to make a perfect teaching recipe for the PG students, how to balance the clinical work as well as the e-learning. So what are the merits of clinical experience? It's definitely interactive, and they can the students can correlate theory with the practical patients. So when I see a patient in the OPD, I immediately call up all my PGs and let them know what these are the findings, and then we have an interactive sessions. Students get to ask questions, and we also can ask the question and ask them to go back and give them the homework as such. So in that we develop the skill development of the cognitive domain, the psychomotor domain, and the affective domain, so which are now very much promoted by the NMC guidelines, and this is what we have to do now when we teach the students. We have to think of all these aspects when we are teaching the students. So again continuing, we have the real life discussions, especially in most of the medical colleges. We get so many book picture cases, so rare cases also. So their communication skill, we ask them to present it. The case presentations are there. So they get to discuss. We need to show them the cases. They ask the patients the questions, and also there is a lot of intercommunication that is much more beneficial. Additional knowledge of systemic associations can also be looked at, and if we need references from or opinions from other departments, so that also can be easily achieved when we have a real life scenario. So immediately we can refer and take opinions of our colleagues from other departments, and definitely the clinical impression lasts a longer. So when they see a case and they write it back in the logbook, and so that stays forever. So again, that is what integration, and it is more structured. Students get to see do the work as well, do all the affective and psychomotor domain challenges are doing. So now let's see the merits of e-learning. Are they yes, merits of e-learning cannot be ignored upon. The clinical knowledge can be gained according to the time convenience. We know that they are hard pressed for times. Resident doctors always have to run between casualty duties to OTs to wards and everything. So when that they don't have as much as time to spend, so they can learn at his or own pace. Whenever they go back in their hostels, they have their gadgets and they can study, and then expert opinion on complex topics is obtained because of we have AIOS programs, we have state programs, and we have so many more other. The students have opportunity to learn from the experts from around the world. Yesterday itself we saw that Dr. Uday Devgande, he was surrounded by so many PG students. So the geographical distance doesn't matter when you have an e-learning access. So impressions of audiovisual aids are long-lasting. It simplifies the concept. You can rerun and see it again and again if you are not able to get it. And it's quite cost-effective. Flexibility and easy accessibility is there. And students know that where they stand on a national platform. So like one of my students is sitting right here. So in a place as remote as Dhulia in Maharashtra also. So there also, because of e-learning, they know they get to present case on the national or the state platform. So they get an opportunity and they know where they stand. So that is also a great advantage. Then they can club together, they can see it in their hostel rooms. So what is now let's come to the limitations. All subspecialty faculties may not be present. Like Purvi ma'am just said, they are, but sometimes the lack of faculties are not there. Availability of all the instrumentations may not be present in all the institutes. And the limitations of e-learning is face-to-face interaction. They may have so many questions while they are watching a video, but they not get the opinion, or directly they can't convey it. And then there's social isolation, technical difficulties. Just now I mentioned about that place. So the internet facilities may not be there. The electricity challenges can be a challenge. and requires strong self-motivation and time management skills. Only if the student is very well motivated, yes, today I'm going to learn this, through those challenges it can be overcome. So again, inadequate tools to similarly, and then lack of physical activities. So you just sit in a place, and so my suggestions are that continuous technical support and blended learning is must. So what it is, so all these needs to come face to face, the community outreach. So you need to blend it all and find out the middle way, that e-learning and clinical experience have to walk hand in hand. Individual institutes can balance the both on availability of infrastructure, manpower and facilitators. And e-learning has made the learning more interesting, but practical hands-on knowledge cannot be done away with. So here's to blend of both, and let's welcome e-learning as well. Thank you so much for your attention. Thank you.
Thank you, Dr. Vaishali, for that very well balanced shown between clinical exposure and learning and the e-learning. And one thing that needs to be kept in mind, especially for the PG students, is no matter what information is available on your fingertips in this tech-savvy world, nothing undermines and overrules the exposure and the learning that you get from clinical experience.
Yeah, beautiful presentation, ma'am. And there is this cartoon that is there. There's a fracture that is shown, and there's a programmer sitting there. He says, I can fix it on Photoshop. So please remember, you can fix it on Photoshop. You can't fix it in real world unless you put your hands on the patient. So I think that's the take-home message, please.
Thank you, Dr. Vaishali. I now invite Dr. Naina for a presentation on coping with stress and burnout in ophthalmology.
Dr. Naina is an accomplished classical dancer. So I think she is the best person to tell us about how to prevent burnouts.
Thank you, sir, for your compliment. Good afternoon, all. Thank you, AIOC, and thank you, Purvi Madam, Jatinder sir, everybody here, Madhav, that we have this small course here where we'll be discussing on the issues of the postgraduate training. They have given me a topic of coping with stress and burnout in ophthalmology, but I think it should be more for the faculties. Because I think lots of faculties here will agree that it's either ways. Both of us are in a seesaw position, right? So after coming to the department with good marks, flying colors in PG NEET entrance exams, students come with lots of dreams, but then their dreams are shattered because the reality is entirely different. They are not prepared for what is going to come ahead. The world is not a very rosy place. So I will discuss the issue in two parts. One is what are the problems they are facing, and secondly, what solutions we can have. So as I said, ophthalmology residency is not impossible. When you stand near the shore, just don't look at the water, don't stare. Jump into it. Once you jump into the water, you will learn swimming and cross across. So this is it. So it's not impossible thing. So as I said, residency is not spoon feeding like the undergraduates. It is a journey. It is a journey of self-learning, which can be done by observation, reading, assisting and interacting. So it's a multi-pronged approach to postgraduate studies. So I'll start with first year. First year is like a basic problem comes from adjusting to the environment, new people, hostel life, work pattern, food. So this becomes a new normal for them, and it really takes a toll on their health. So along with this, then there is patient responsibility. Till internship, they are like in a blissful world. Here they have to start taking the responsibility. Then according to their own terms and terminologies, there is a word called toxicity, which I am hearing quite often. So they say that seniors are toxic, right? So this starts here. Then they have to don multiple hats, from mama to sister to everything in the first year. So it's a multi-purpose role. Then they are on call. They don't know what to do when they are on call. So that is the time when things start striking them. So they are lost, and during that they are not well equipped with knowledge. So they have to read. So all these things again take a toll on their mental health. So there is this cycle which I have put. Lot of long working hours, huge patient workload with lot of physical stress, sleep deprivation, absent, or I shouldn't say irregular eating, absence of food intake, homesickness, loneliness, leading to anxiety, depression. It's a big cycle and it's very difficult for us to break. But yet they have to understand this is a part of first year and move on. So second year they are a bit eased out. They are in the safer zone, not much responsibility. Plus they don't have to do the running around and the jugglery. And they now learn to manage emergencies. So they are a bit chilled out. But then they say, see, this is what I had given a questionnaire to our student. So again, I'm using their terminologies here. So they are saying that we are sandwiched. Although they are at ease, they say we are sandwiched. Why? Because the seniors boss over them, the juniors don't listen to them. And then they feel, oh, we have to learn so much now. So they feel that the learning curve is very steep. Third year, along with all the patient load, they have to read, they have to take lectures, they have to do publications, present in conferences, and the most important is the thesis work. So here they start learning lots of things. They try to take decisions in casualty. They coordinate with juniors. They try to become more of leaders, so that if that bossing element goes, they can be at peace and the juniors can be at peace. So, and also finally, one thing I feel in all these years is time management, which the students have to learn. They have to really understand what should be given more time. So what should be their goal? They have to remember that this is a 3-year investment for lifetime and for future. They should avoid distractions, no social media, or curtail the social media interactions. And this can happen only if they are self-motivated and enthusiastic themselves. So what best can be done in the scenario? We can't change much here. Work is going to be there, learning phase is going to be there. So what they have to do, they have to start a day afresh every time. They can do a small meditation, 10 minutes they sit back, close their eyes, relax, and think about what best can be done. Okay? So then another thing what I feel is they should distract from this all curriculum by doing extracurricular activities. They can go for a short jog, they can go for a gym, half an hour, speak to friends, intermix with the other specialty peoples, talk to their parents. And one thing I feel, they shouldn't stress on future. The moment they step in, they start thinking about their future. They have not yet passed MS, but then they think of long issues, long things. So they should take one day at a time. And always, as I say, look at the positive aspect of everything. See, the coin has two sides, so don't look at the negative side, look at the positive side. Always be optimistic. And as I said, talk it out with friends, family members, and counselors if possible. You can seek professional help. And always remember that this is a passing phase, this is a journey. That is, residency is not an end. So this will also pass off. One vital thing I feel is health. Nowadays students, they fall sick because again they don't eat, or they order from Swiggy, Zomato, they eat whatever crap, we call it crap, but then that is their important food. So that junk food should be eliminated, that is important. Then catch up with sleep whenever you can. Even in the OT recovery, you can take a small powerful nap, right? And as I said, the small routines of exercises, stretching, deep breathing will prevent this further sickness. Now comes the main part. You have to understand the subject. You have to observe, listen, communicate. Whatever you read, you discuss with your juniors. That helps in retaining whatever you have read. Also discuss with your seniors and teachers. Surgical skills also, you should have a lot of practice on the goat size, tomatoes or whatever, wherever, whenever you can. As Madam said, Dr. Vaishali, e-learning, yes, that is the most favorite platform. Yes, that also will help. You attend, various wet labs, hands-on programs, that will also benefit. And the most important thing, which is mandatory by the MUHS, is the maintenance of logbook. So you know what you do and where you stand. Communication, this is again an important aspect. This is very important when you talk to patients, also with colleagues, that interpersonal relationship and behavior is also equally important. That will lead to less toxicity and also be respectful to the seniors. Right? Again, I said toxicity, that word has got in me. So you can just talk it out. Learn sharing and caring, that will also help you come out of the situation. And finally, I say that believe in yourself. You are here with a purpose. You are here with your hard work. So remember, do not get carried away by other people's opinions. Believe in yourself. Believe in yourself. You don't need anybody's validation or approval. If somebody says you are bad, don't assume you are really bad. If somebody says you are good, yes, stay grounded. And if things, in spite of being nice and all, if things go out of hand, you can stand up for yourself. But being vindictive during residency doesn't help at all. And surround yourself with the right people, right group. Focus on the subject. Do not fall into traps and addictions, which will lead to self-destructions. Do not participate in unwanted gossips. Manage time, as I said, which is precious, crucial. Take your faculty into confidence, and as faculty we can also do a lot of hand holding here. We can supervise and monitor the work, the delegation of work. We should be approachable and we can be a good mentor to the students. So I think you should not follow this Mahatma Gandhi's 3 monkeys principle here when you are doing residency. You be a good listener, be a good observer, be a good communicator. So finally, the checklist for sailing through smoothly in turbid waters is be polite, be sincere, hardworking, proactive, patient and empathetic. Empathy is a new thing which also helps us stay grounded, as I said. And finally, take home message, the mantra is believe in yourself, forgive and forget, move on and progress, focus on good, don't repeat your mistakes, don't be vindictive, do not give up. Our life is very precious. Thank you.
Excellent presentation, ma'am. So at the end of the day, what you need to realize is that it's just a journey. And, at the end of 5 years, all this toxicity that you are encountering is going to pass. It will no longer be there. What happens is when you're close to the event, even a small scolding that one of your seniors has given you, it appears very big. But believe me, after 4 years or 5 years, you're not even bothered about the toxic people who entered your life. It's a journey. It's like a train journey. People will join you. People will leave. So try to pick up the good people. And now I call upon Dr. Purvi for talking about developing surgical skills, challenges, and best practices.
Thank you, Dr. Bali, and thank you again, everybody, for being a part of this IC. And I'll be now talking on developing surgical skills, because when you enter the surgical branch, the MS word itself that fascinates is the surgeries that you do and surgical outcomes that you give to your patients. So what are the challenges that exist in the current training scenario and what best practices we can adopt? No financial interest to be disclosed with respect to this presentation. When we talk of ophthalmic surgery, we need to understand a few things about how it is different from other surgical branches. There is a lot of precision that is involved in our surgeries. We work in a very small and confined space with very fine instruments. So a lot of precision is required, lot of dexterity is required, lot of hand, eye, foot, brain coordination it is required. Even a smallest amount of surgical error that can happen, a small suture gone loose or opened up, a small descemet membrane detachment, an IOL slightly decentered, all of them can have a significant impact on the patient's outcomes in the form of visual acuity, in the form of quality of vision, and in the form of the effect on the quality of life of the patient. And we all know every AIOS and other conferences we attend, we keep on seeing new techniques and new technologies and new systems that keep coming up. So there is a constant need for the postgraduate students as well as ophthalmologists in general to continually adapt to these changing circumstances and continuously keep in the learning mode. Now, there are certain challenges in the surgical skill development and training. There are these challenges from the patient perspective, from the student perspective, from the educator or the faculty perspective, and the overall system of education per se. So from the patient perspective, there is a variability in the patients. Cataract surgery is learned maybe in a fixed defined areas, like you need to have a good dilated pupil when you start learning surgeries, the cornea needs to be healthy. So the learning happens in a predefined sets of cases. But when you finally start operating, you learn that each patient is individual. Each cornea is different, its posterior capsule is different, its sclera is different. So that surgeon adaptability to different complexities, different disease profiles, ocular profile is different, systemic profile is different, anatomy is different. That adaptability needs to be developed. As I said, fine motor skills are needed, and it is very, very challenging to master all these skills without extensive training. In many of the scenarios, institutes and colleges, they do not have an observer's tube. There are no CCTVs, no displays, and no fancy gadgets. So it is very, very difficult for the faculty or the senior who is assisting to actually guide, supervise, observe, and take charge of when necessary. So this limitation of ophthalmic microsurgery, that is one-person microsurgery concept, it limits immediate supervisor intervention, which increases the risk of surgical errors and complications to some extent. However supervised and informed the surgery may be, ethical concerns do exist about novices and trainees performing procedures on patients. And the patients are awake most of the time. We operate under local or topical anesthesias. So giving a real-time feedback to the students when they are operating is sometimes very, very difficult because they are constantly receptive, the patients, to whatever chatter and talks and conversations they are happening during their surgeries. And the next day they are bound to tell you that they know that their surgery was done by, maybe a trainee or maybe a less experienced person. There are some inherent gaps in the curriculum and the structured training program itself. One is the curriculum is still not standardized, not very structured, and not uniform across the country. In spite of the PG NMC curriculum coming in place, it still focuses on the cognitive domain, to some extent on the psychomotor domain. But the surgical domains and the soft skills, they are still not overtly into the curriculum, still not structured. They do ask for a mention of how many surgeries and procedures have been assisted, supervised, performed, observed. But what about the quality of the surgeries done, and what about the competency? That is not mentioned. There is limited exposure to diverse surgical cases. Across the country, various geographical regions will have different patient exposures. Some areas may have more pterygium, some may have less pterygiums, more cataracts in some institute, less cataracts in some institute. So ultimately, at the end of the year, if you see the number of PG trainees that come out after having their MS degrees, their competency levels are very varying and in a huge range. There is insufficient emphasis on non-technical skills. Whenever we talk of surgical skills, we focus on how they handle the tissues, how they are using the instruments, and what is their visual outcome the next day, whether it is 6/6, whether the cornea is clear, and all those stuff. But there are a lot of non-technical skills which are associated with the surgical aspect. How they behave in the OT, how they talk with the sister, the nursing staff, the supporting staff. If the patient gets uncooperative, how they talk and behave with the students, the decision-making capability, that leadership skill in the OT. If a complication happens, how well they can judge and take charge of the situation. All those non-technical skills which form a part of surgical training, they are not there in the curriculum, and neither do we teach them. There is inadequate utilization of technology because of the cost issues, infrastructures issue. Again, each institute and college has their own set of equipment. Limited mentorship opportunities and inadequate assessment methods. Till date in the exams, we just focus on the cognitive domain, to some extent on the psychomotor domain. The what and why of the different things and how to some extent. But we never assess the surgical skills. surgical skills are never assessed. We do not grade them. We do not allow them to step up in a structured manner. So that assessment component is still lacking. There are tales which come from the student perspective from the operating room itself. Each student has a different learning curve which we as faculty need to understand. Each surgery, each complication of surgery has a different learning curve. Time pressure, again, as Dr. Naina very rightly mentioned, managing so many things on different fronts. Again, that time pressure is there. They need to cope up with the stress and fatigue. They also need to have a balance between confidence and humility. Confidence as in to take decisions and operate properly and in a wise manner with good wisdom. At the same time, to be humble enough to acknowledge their mistakes, identify their weaknesses, and seek feedback, opinion, and guidance from the mentors or faculty. So that balance between confidence and humbleness needs to be there. And of course, as I mentioned, navigating through the different interpersonal dynamics needs to be there. So how can we in different ways try to address these gaps? One is a structured training needs to be there. Training programs need to be standardized and uniform across the country and addressing various levels of skill from basic to advanced. Objective assessment needs to be incorporated. Even though it is not part of the NMC guidelines or the curriculum, at individual levels, at departmental levels, we can start incorporating assessment of the surgical skills. Various rubrics are available on the ICO portal. There are n number of rubrics for different surgeries which are open access. We can make use of them or maybe even design and validate our own rubrics. But an objective assessment of surgical skills with a continuous constructive feedback needs to be there. Simulation training, again, as just discussed, they are vital in the surgical training forum. They provide opportunities for repeated practice, allowing to make deliberate mistakes, learning from them, and it's a safe and practice environment where the students can go back repeatedly and keep performing different steps. And all this without having any patient risks. So this will increase their confidence, and it will also allow them to operate with more finesse and giving more predictable patient outcomes when they actually operate on live patients. Different types of simulators are there, something very crude as like fruits and vegetables and all those things for practicing dexterity and suturing and other stuff. Then we have high-end simulators. We have, of course, the SSTC. We have the AIOS Prayogshala now. Different gamification sites are there where the students can learn different surgeries and steps. And, of course, the AR and VR-related simulators. So whenever technology is incorporated into learning, it provides an opportunity for enhanced visualization of different structures and tissues. The higher the fidelity of a simulator or a training system, more closer it is to the realistic scenario. And as just discussed, it provides an e-learning atmosphere. The students can record their videos and share it to a faculty somewhere else, maybe the cataract coach sitting there, and they can invite feedbacks and opinions. And surgeoners are, of course, there where the students can view and learn from them. And all these high-end technologies, they have this inbuilt tactile feedback, auditory feedback, and other scoring systems which allow the students to step up level by level. We need to encourage the students to continue learning and continue upgrading their skills from different conferences, enroll in wet lab courses, mentorship, of course, Dr. Usha Madam will be talking in a while, and also encourage peer collaboration, wherein they can discuss about their strengths, the weaknesses, different aspects of the entire surgical training, and they can learn from each other themselves. We also need to teach them, while talking of surgery, about the ethical practice. No matter what, patient safety has to come first. You may have promised a sutureless surgery to the patient, but on table, if you need to take a suture, they should not hesitate to take a suture. Of course, the patients need to be informed about this, but that ethical practice and decision-making needs to be imbibed while the surgical training is on. And of course, self-assessment and reflection. At the end of each surgery done, the students should be encouraged and motivated to reflect on their surgery, discuss what went wrong, what was good about the surgery that they did, and how they should move about and improve in the future. And of course, patience and persistence. No matter how many failures have happened or complications can happen, the students need to stay motivated, and faculty need to keep motivating them so that they can keep improving and keep learning. So at the end, mastering surgical skills in ophthalmology is fraught with risks. There are technological demands and training gaps, but this complex nature itself demands a comprehensive approach. So at the base, we still need a structured, standardized, uniform training program, a curriculum integration, mentorship needs to be in place, simulation fidelity needs to be incorporated, objective outcome measurement, that is assessment, along with a constructive continuous feedback needs to be there, and the students need to be encouraged for reflection and for lifelong learning. Thank you.
Thank you, ma'am. Dr. Purvi, that was a very comprehensive talk on the subject, and she's right about the variability in surgical skills being transferred. There was this study that was done, and there was a median number of surgeries. So the median number of phaco surgeries that a resident was getting at the end of 3 years was 1 phaco surgery. At the end of the median is like where you have skewed data. You have some institutes which are giving say 70, 80, and then you have institutes which are giving 0. So they did a median. So the median was 1. If you're exposed to 1 phaco surgery, what kind of a skill set is it that you're going to take? Then what we did was we came up with something called the competency based system, which was the traditional Indian approach of everything. We said let's make a logbook of everything. So the logbook is sometimes copied from the previous one or the one from the previous year, and at the end of the year you just sign it. So what we're trying to do here is we are trying to think ahead. There are so many things which are available, and she's very rightly said that you have to go back. It's a continuous learning process. So what teaches you the most is your own surgical videos or those of your peers. So if your institute has a recording facility, that is the best thing that you can have. Record it, and then at the end of it, review it with somebody senior, and let it be. See, the point is that it's not, it's a critical evaluation, a formative assessment, a formative evaluation. Try to improve from the last mistake that you made. And with that, I think I will now call upon Dr. Madhav Ambekar, and he will be talking about ethical dilemmas in patient care during postgraduate training. Now this is a very, very complex topic, and especially for the youngsters, it's an eye-opener.
1 second, sir.
He'll be navigating you through a lot of pitfalls, and you are actually doing it inherently every day in your life. It's only when you realize that this is what I'm doing, you start realizing how important that is.
Thank you, Purvi madam, for giving me this opportunity to be a part of your IC. But anyway, this subject of the ethics for the sound practice development is to my heart since long time, because probably ethics, following the ethical practice only gives you the contentment in the life, for which I'll be talking for next few minutes. And now, because this was absolutely lunchtime, so few might have had the hypoglycemia causing the sleep, or somebody might be hyperglycemic causing this. So I said this is the thing can come out with the for an awakening exercise for all of us sitting here. That's fine. So ethics and the morals is highly subjective thing, as I have always felt, And what I feel ethical, somebody may feel is to be, it's not an ethical thing, and the morals is again a very individual kind of a thing. So advertising cataract surgery with 6'6", advising someone a cataract surgery at a 6'6" vision who is say 70 around age of years, are we ethically right? I think that's something that we need to understand. Because in the current scenario, in the scenario of the usage of the social media, everybody is doing a lot of blah, blah, blah. And so effectively, and everybody starts feeling that unless you do blah, blah, you are not a sellable commodity. But I think sales is not the only thing for us to understand, but it is something beyond that, is the contentment and doing the good job for, because you are dealing with the patients as a human being and you are not dealing with the machines. So there is a mind inside the body, and that has to be addressed, that you are looking for the patient as a human being. Society and the medical fraternity, gone with the wind are the days where our predecessors have enjoyed the highest level of the to being a god, or next to the God, almost, kind of a thing. And now everybody, the society members look towards us with a lot of suspicion. And but then finally we need to understand who started this. Ek haath se to tali bajti nahi hai, but then somebody might have started it and ignited the current through which this has started, and because of which now everybody in future is going to face these consequences. And probably just before go on the next slide, I think COVID for all of us was a golden era to prove ourselves that the medical community is doing a sincere job. But unfortunately, there are a lot of hospitals which you might have come across to know in the newspapers that whether the biosimilars were given or not given, because that was one of the very expensive injections at that point of time. So honesty, the compassionate ground, and the most important is the transparency at work. Because somebody advising some cataract or for the open angle, I come across sometimes that somebody has advised the laser PI and everything, and then patient sometimes comes, sir, I could not do it, and now am I going to land into the problem? And then you realize that somebody has already advised for the laser PI for the open angle. So I think what we need is the stewardship towards our work, and which is the most important thing to maintain the nobility of our profession. Unless we maintain the nobility, the society will always look towards us with a lot of suspicion. And are we really deviating from our oath? Because what has happened in the current scenario is people have started thinking that I am attached to this big institute, I am attached to that big institute. But all regards to one of the mentors is Dr. Usha sitting here, that she always confidently says that I am a solo practitioner in a city like Mumbai. So I appreciate her way that she carries to say that I am a solo practitioner. And I am also a solo practitioner, but then recently joined by my daughter also. So various different business models can be thought of, but then finally ethics will continue, and corporate owned versus the doctor owned hospital, because I have come across few of the doctors, those who were trying to be ethical, and then finally they were told, since your cataract outcome is less, so now probably 3 months down the line, we are noticing that your cataract outcome is less than 10%, 20% every month. So better that either you improve or you perish yourself. Improve or go out of this institution, because you are not supporting to the institutional the revenue generation. And all this started probably once the MBA people have started taking over the doctors as a management side. So doctors started themselves withdrawing out of management, where I have a lot of things to be on the management side also. I have come across, because few of the professors are sitting here, then they can always be the part of this, saying that public-private partnership model, which I am trying to propagate in Maharashtra, but then unfortunately in the current political scenario, I am not able to follow up this dream of PPP model. But if they can be of some help, or she's also there as a professor, that we outsiders have some set skills, and the government can invest into the instrumentation, and we go inside and operate it, something of that kind. And otherwise, because unless we start thinking in the different business models, everybody, because finally end of the day, it is all that how much money with a reasonable outcome that you take for the amount of the investment of the year of the life you have spent into the learning. So this becomes the most important thing, which probably might be the reason to deviate from the oath of the service to the humanity. So what we have to introspect our own self, accept the corporatization. I don't deny that corporatization is going to go out, but then accept in a graceful way, and because the moment the mall started coming in, people started thinking that the grocery vendor who is next to you probably will disappear, will get perished, but this has not happened.
Aspects of learning and education, which are the heart of education, like professionalism and ethics, they still fall under the category of hidden curriculum, so to say. So now I invite Dr. Jatinder Pali, sir. Who will be evaluating the current ophthalmology curriculum and assessment.
Well, like Madhav sir said, money can't buy you happiness. I say, let it buy the misery that I enjoy. All right, thank you so much. I think I will be talking about the current status of curriculum evaluation and assessment. The basic idea, I'm working in Delhi in a 1,000-bedded hospital attached with a medical college, and I'm the DNB coordinator there. And the basic idea of this talk is to start thinking about how to think. So my task has already been made very easy by Dr. Purvi, Dr. Nayana, and Dr. Vaishali. I will be throwing a lot of concepts at you, and there are these handouts that have been given out. The details of those concepts are going to be there. So it's when I touch upon those concepts, I will not be elucidating them in great detail. Now, I do not have any financial disclosures to make for this particular presentation. Now, when we come to curriculum, we think of a document. A curriculum can mean a document, but curriculum actually is derived from the word career, which means a race course, which means the runway on which one runs to achieve a goal. It is the path to get to a goal. It is the total structure of all the ideas and the activities, the course of studies, the methods of teaching, the extracurricular, the co-curricular activities that are there in addition to the regular program. So we talked of, curriculum. What have we got? We've got a traditional curriculum which was enunciated, a decade and a half back, and then again re-enunciated. I will not go into the details of it. So there are basically, any curriculum needs to look at the basic needs, social aspects, cultural factors, but most importantly, it needs to look at the individual talents and the ideals that are to be achieved. There are certain tasks in curriculum development which are outlined here. Now, how do we develop a curriculum? First thing, of course, is you need to diagnose the need. Is there a need to develop the curriculum in the first place? And then based on that need, you formulate the objectives. Then you plan. What is your content? How are you going to deliver the content? How are you going to organize the content? That is the planning stage. And then you select the experiences with which, the person will learn. And it does not end there. You have to go back to the drawing board, keep evaluating how effective that curriculum that you have developed is. Right now what is happening is, we are training the medical students of tomorrow with a curriculum of yesterday with tools of a still older era. Luckily, the e-learning platforms were discussed, and that is a very big game changer. The simulators and the e-learning. And how do we integrate them into the curriculum? That is a very big question that we have right now. Now, what can be the orientation of the curriculum? Right now it is knowledge-centric. It is not student-centric in our case. So we've already talked of, the process of the curriculum development. Just remember that the three phases are, first you develop it, then you implement it, and then you go back and you evaluate it. Implementation also has some evaluation incorporated into it, which is a monitoring. That means you're testing while it is running. It's like, when you're driving a car, you're looking at your instantaneous speeds. You're doing 20 kilometers, you're doing 70 kilometers. This is monitoring. And then at the end of reaching the destination, you say, okay, I drove 45 kilometers an hour. That is your final evaluation. So what this leads us to conclude is that any curriculum has to be continuous, it has to be comprehensive, it does not have to be abstract that, something like this will happen or that thing will happen. Concrete ideas are required, and then of course it has to be cooperative. There are these 9 competencies of medical curriculum. All of us know them, all of these are discussed. Now we talk of, effective communications, the basic clinical skills, lifelong learning. Now what I want to focus on is the next 3: self-aware, self-care, and personal growth. These are the aspects which are right now relegated a little to the background, which we need to bring forwards. Then of course, you'll talk of the social and community context and the moral reasoning and ethical judgment, as Dr. Ambekar has already talked of. Now, what is happening is, like Dr. Purvi said, that, we are embedded in a highly cognitive, that is, give them a few facts of whatever X, Y, Z, and then expect their behavior to change because of those facts. So we are in that, cognitive and behaviorist model of learning. It is reductionist, it is not suitable for clinical settings, and I will go ahead and prove why it is so. We've already talked of the different domains of learning, the cognitive, those knowledge aspects that you learn. The psychomotor, then of course is, you internalize that knowledge, it alters the way you feel about things. So there is an affective domain that gets modified, and then of course it becomes a behavior. That is your psychomotor performance. So there was something called the Bloom's taxonomy. This was given in 1956, and what it said was, you need knowledge first of all, and then you need to comprehend that knowledge, understand it, then you need to apply it, then you need to analyze how it was applied, then you create further knowledge, and then you evaluate it. In 2001, we realized one thing, that you cannot synthesize before you learn how to evaluate. So what we did was, there was this Anderson's modification, where all these nouns became these verbs on this side. I don't know whether you can see it there. So the only thing that has gone is that evaluate, first you need to evaluate, and then you go into creating the content. Right? Now this is focused on the residents very specifically. Right now what is happening is, the moment you're exposed to something, you say, okay, I can, so and so YouTuber is doing it, I will also do it. A lot of our people are also doing it, but please realize that there is a particular level of proficiency beyond which you should start working on that. And then of course, we've already talked of the factual knowledge, disconnected facts. In those disconnected facts, what are you doing? You're developing connections in those disconnected facts. Then, using those connections, now you use procedures to do things. And finally is the mega cognitive aspect that we are talking of. How to think about thinking. How to approach how we think about thinking. Of course, we've talked of the hierarchy of the cognitive domain. So basically, the knowledge is going to have, an internal structure. And the second thing it is going to have is how well it is suitable to the world outside. So it has an external validation, it has an internal validation. Psychomotor domain, Dr. Purvi is already talked about it. First you decide to act, then you start imitating another person's behavior, which in our case is, somebody senior. Then you start acting without those cues, and you modify as and when it is required. And then finally you develop procedures and processes of your own. Now that brings us to the question of curriculum evaluation. Now, who should do curriculum evaluation? Now there is no such fixed criteria that so and so will do it. When you're doing something like at the end of the procedure, or you're doing it for the bureaucrats or the common public, better to have a third party certification agency or people who are not closely connected with the process, so that there is a level of objectivity to it. But when formative assessment is there, when you're doing prescriptive, when you're looking at the curricula in a manner that you're going to, if you feel that something is missing, something is not working, and you want to reorient it, then better to get the people who are teaching, who are working within the system. How to do it? There are many models. I've already given in the handout. There's Tyler's model, there's Serivan's model. In one model, he says what you do is, there are goals, and this is the outcome. So compare the goals to the outcome. That is Tyler's model. Then he says, Serivan's is goalless. He says, let's not look at goals. We will evaluate it and have a descriptive kind of a thing. And then is, of course, one of the models which is very frequently used. It's called the CIPP model. That's content, that's input, the process, and the product. Right now what we're doing, we are just evaluating the product. We are not looking at, the processes, the inputs, and the content. And then, of course, methods of assessment we've already covered. It could be, in the olden days it was those tests and those rubrics. Now it is possible to have real-time, online examination systems which tell you on the fly how well you're performing, right? And then, of course, the rubrics of assessment can be debated, discussed endlessly. Then, of course, we are left with the question of formative versus summative assessment. Broadly, formative is something which is while the process is still going on. So when you have, somebody who's his first year exam, his second, like you take an exam in first year, you take an exam in second year. Now the purpose of this exam is not to pass or fail the student. It is to understand where the training process is going wrong. So this is where we are making a huge mistake. A lot of people are making a huge mistake. They don't understand that there is a prescriptive element and a diagnostic element to formative testing, right? And then of course summative assessment that we do at the end of 3 years is actually formative assessment for curriculum evaluation. And I think that covers about everything that I wanted to talk about. Thank you so much, ma'am.
Thank you, Dr. Pali sir, for that piecemeal evaluation of curriculum and assessment. And now I invite Dr. Usha Johari, madam, for her presentation on the role of faculty in mentorship and guidance.
Somebody in Delhi will say it has to be done. In 3 weeks' time, somebody will copy and paste it from some other document, either in another country or in our country, which is 10 years old, and then he will supplement it with a few of his own random observations. Unfortunately, the people who are teaching, all these people, their inputs are not coming into it, and the reason for it is these teachers don't have a voice in the policy making. That is the unfortunate part.
Perfect.
Yeah. At the outset, I would like to thank, a special thanks to Dr. Purvi, who could arrange this IC, although an odd time, but still, I'm happy that at least, I can see few young and elderly surgeons in this hall. And all my previous speakers have covered most of it. I'm just going through, run through a few ideas of mine, which may be theoretical, maybe in future, over a period of time, it could be, applied. So in my opinion, mentoring is basically a brain to pick, ear to listen, and push in the right direction. So it helps us to manage the relationship, it encourages each other, nurtures, teaches, offers mutual respect, and responds to the mentee's needs. And I'm sure you'll agree with me that a mentor is one who sees more talent and ability within you than you see in yourself, and he or she brings it out. And in ophthalmology, yes, mentoring is a serious business, both academically and surgically. So let's quickly go through what was the origin of mentoring. The king Odysseus had his friend whose name was Mentor. So when he went for a Trojan war, he introduced Mentor to his son Telemachus, who became an excellent assistant or an excellent prince who could manage army. Next came the Alexander, who at the age of 13 had a mentor, Aristotle, and who taught him politics. And we should be very proud to say that the key architects who shaped India and the destiny of modern India were none other than Mahatma Gandhi and Jawaharlal Nehru. And world Olympic cyclist, Lance Armstrong, his mentor was Eddie Merckx. So in my opinion, mentoring is extremely important. What exactly is the mentee-mentee relationship? The goal of a mentor is to ignite the constructive spirit of a mentor and encourage the mentorship. So the potential mentors should become ideal mentors, not that we are all good mentors or mentees, and the potential mentee should gain the right knowledge from the mentors. So what are the expectations of the mentor and the mentee? There could be very good expectations which are very useful. You take what you want and just throw away what you don't want. Sometimes there could be unhelpful expectations like, wanting too much, which can really create an havoc between the mentor and the mentee, and which is, I think, in the current scenario of medical colleges and institute is the case. So the expectations of the mentor, are they important? Of course they are important. Mentoring does matter. Why is it running? Mentoring does matter, and the art of mentoring requires two things. One is a skill, and the other one is an attitude. Now, do we have an answer to all this? No, we don't have it. But as a mentee, there are a few expectations. That's be available, provide them the right direction, support the peers, and be a little professional. Okay? being a mentor is definitely a challenging task. Now, what are the expectations from the mentor? I'll just run through quickly one by one because I think the next session people are already in, and I'm lucky to have them because they're wanting us to, vacate the hall. So understanding the student and developing a comfort zone, which is so important, which is not seen in nowadays. We as students saw this. That's why I'm talking about this. Understanding the platform where the student stands. We all think that the student who has come, is meant to read and come, but it doesn't happen. And can we not perform few tests to understand where the student stands and what is his knowledge? And most important thing is take the decisions of what is to be unlearned and relearned, which I think is important. Can we not start from a scratch? Yes. If I remember, what I learned in my postgraduate days is still there with me, last 40 years. And you'll agree with me that the first lessons learned from the mentors will remain the longest. Eye contact is so important. In this era, where there are all gadgets available, knowledge is available all over in bits and pieces, can we not have consistency, confirmation, and repetition, which is the key of success? Patience. All my previous speakers have said how much of patience we should have. Let's try again and again. And not all formulas work for every student, right? Some may be, extremely intelligent, some may be very smart, some may be dull, some may be over smart. We know all this, isn't it? Can we not listen to the students? Because they are the wonders and they have excellent imaginations which we cannot think about it. Give them time to breathe. I think in medical colleges, they don't have time to breathe. And consolidate what we are teaching. Homework, extremely important. Even now, when at this age also, when I go back home, I write down in my notebook what I have done today and what I'm going to do tomorrow. The younger generation might write it on a PC or in their mobile. But we all know that practice makes a surgeon better. Isn't it like driving a car? If I don't drive a car for 2 days, I really don't know where to hold the steering. I don't know where is the brake. So quality comes with careful planning, allographic approach, and meticulousness which every surgeon must have. Difficult surgery should be introduced early so that the worst scenarios are not dreaded. Keep checking your homework and keep updating yourself. There's, you can learn every day. Holistic approach, which is lacking so much. Surgical steps, complex surgeries alone are not enough for you to become a very good surgeon. Before you plunge into this big bad world, equip them with basic artillery. Lead by example. Embrace all the limitations of yourself and your student. Last, pardon them, excuse them when possible, punish them firmly with positive lessons, cover wherever you are required. You cannot expose your student or you cannot expose your colleagues, which happens very frequently, and I'm sure you're all aware of it. And humiliation is never the answer. Can we not think of passing over the baton? This can happen only if you have a very good relationship between the mentor and the mentee. Okay? Pass the knowledge, teach whenever an opportunity arises, and find interesting grounds and collaborate with the next generation. So this is what, I think an ophthalmologist need to understand in a nutshell. Role of a mentor is so important. You can act as a role model, a door opener, a teacher, a guide, a counselor, a coach, a motivator, and of course an advisor. What is a mentorship skill? A mentorship skill requires a trusted friend and an advisor, skills needed by an effective mentor and skills needed by an effective mentee are equal, almost equal. Listening actively, both of them have to listen actively, building relationship and ability to encourage. When a mentor encourages the mentee can also encourage a mentor. It's vice versa. So there are some workshops of mentoring, which I'll not go into the depth of it. Understanding mentoring process and skills required for mentoring. There are different types of mentoring. In brief, I have just covered 3 types: the peer mentoring, the group mentoring, and the professional mentoring, where the difference between the mentor and mentee is just a little, age difference, very little age difference, almost of same age. Group mentoring, where we are mentoring many people, and the professional mentoring, where the major difference is in the life experience. Coaching and mentoring are 2 different aspects. Coaching means you're developing a skill which is very specific. whereas mentoring is for a career and it's a broader term. So at the end of the day, can we ask, our mentee, did mentoring help you a great deal? Can we not make it clear to a mentor that I want to become just like my mentor? This is a question that I would ask my mentor. And I think the person whom I was mentoring was good enough. So I really learned something from my mentor. And mentoring, let me tell you, I would conclude saying that mentoring is not a counseling service. It's not a drop in the advice center. It's not an academic tour, but neither it is not an answer to all the problems. So mentoring is a two-way street. You get what you put in, and it's really difficult to find a good mentor and impossible to find a good mentee. And let me conclude saying that mentor is just a facilitator. So the ultimate secret is we grow when we teach. Thank you very much for your attention.
Thank you, madam, for those excellent tips of mentorship, and that was a very important word that you used, that is role modeling. Because no matter what we teach and preach to our students, if we ourselves do not practice it, the students are not going to learn it. Because only a part of the transfer is through teaching and preaching. The most of the skills are learned by observation. Thank you.
And my take-home message, especially to the youngsters, would be when I was young, we had, in school, we had a coach from Oxford who would come to teach us football, but he taught us fantastic cricket. And what he used to say was, don't practice till you get it right. Practice till you cannot get it wrong. That is the acme. That is what it should be.
The hunger which a mentee should have, okay, I remember during my school days, when I used to go for some special classes, my mentor or my teacher would tell me that you want to learn, so you come to my doorstep at 4 o'clock in the morning, wake me up, I'll have a cup of tea and then I'll come to your place to teach. So the hunger of the mentee has to be there to encourage a mentor to teach.
Nowadays, I would wonder if the mentors or the mentees are getting up at 4 o'clock in the morning. Because many of us are actually sleeping at 2 o'clock at night.
We got the session about 8-9 minutes late, but we are giving it back a little earlier.